A warm welcome to Health and Lifestyle. My name is Marie Yambo. Our social media handles, as usual, at KBC Channel 1 on X is where you can interact with us. Now, every day, 16 women, translating to 6,000, die from pregnancy and childbirth complications in Kenya. Going to the clinic early, having skilled health workers around, and getting timely medical care can literally save lives. Across the country, new initiatives are stepping in to close these gaps, making sure that expectant mothers get support they need, not just at the hospitals, but right in their communities. That is going to be our focus in the Health and Lifestyle Show today, but first a look at what's coming up. Coming up, early antenatal care saves lives, a mother's journey through pregnancy. Bridging gaps in maternal health care, how free pregnancy tests is saving lives. And on good practice, we look at health tips for safe pregnancy and delivery. Welcome once again to our first segment. For Brenda, her first two pregnancies were a bit of a guessing game. Like many women in rural areas, she only went to hospital when she started feeling unwell. But everything changed with her third pregnancy. This time, she made sure to start clinic visits early, and she noticed a difference. Here is her story. Brenda is a mother of three. Today, she attends clinic at the Gataka Health Center in Rongai, Kajiado County. In her earlier pregnancies, Brenda did not attend clinic early. She didn't even fully understand why it mattered. Like many women in her community, she waited until she felt unwell.
Wajua ile wakati ingine tulikuwa tunapima vitu zote na vitu zingine wako tunajua zinafaa zipimwe mapema ndio wajue shida iko wapi. Lakini kama ile ingine nilikuanga na shida ya kizunguzungu sana. Unapata saa zingine tena niko na uchovu mingi bila kujua.
But everything changed in her third pregnancy. This time, Brenda started clinic early.
Naona kuna utofauti because wakati tulikuwa tumeshika ujauzito, hao watu wa St. John ndio wakaanza kutembea, ndio wakaanza kutuelezea tuende kwa hospitali mapema, tukujua hata kuna mara ya kwanza, ya pili, ya tatu. Na ile zingine sisi tulikuwa naenda tunakaa hata miezi 7 tunaenda tukikaribia kumaliza. Lakini hii kama huyu nilienda mwanzo. Nikifika miezi 3 already walikuwa washapita washatuelezea ndio nikaanza kwenda clinic mapema.
For the first time, Brenda says she felt supported not just by nurses at the hospital, but by the community health promoters who followed up closely.
Hawa CHPO kitembea wanakisha wamewafuatilia kila siku watakuuliza kila mwezi nipea report. Hii itakufanya lazima utaenda clinic. Ndio kiitisha ukue nayo. Umeenda clinic ndio hii report imeenda. Lakini unajua usipoenda utawapea nini?
The real difference for Brenda became clear on the day she went into labor.
So kama huyu ilinipata kama wakati yenye nilikuwa usiku sana. Na in mind nikawa ninangoja nitafute taxi nini nikapata wote hawapatikana, mvua ilikuwa inanyesha. First nilitafuta huyu CHP wetu huyo. Ndio nikampigia simu nikamwambia mimi siko sawa, naona kama ni wakati umefika. Alichukua jukumu. Alifika hadi kwa nyumba. Kufika kwa nyumba akanitoa mwenyewe paka tukapanda pikipiki, tukapata paka vile tunapata gari penye tulikuwa tutokee paka kwa barabara. Tukachukua gari hadi wapi? Hospitali. Akaitisha report kila kitu. Mimi nilikuwa tu nikupeana majina kila kitu basi. Paka hadi akangoja nikajifungua.
That night, Brenda delivered safely under the care of trained health workers, a support she believed saved her life.
Ile wakati sasa nikienda kuzaa unapata nikishajifungua ninapatikana sina damu, niko na damu kidogo. Lakini sasa huyu ile changamoto ilikuwa tofauti because nilianza mapema. Nikaanza kukula matunda, mboga, maji vizuri, kupumzika vizuri, exercise nafanya vizuri, naenda check up kila wakati. Kwenda mapema hospitali ni vizuri na kujifungua hospitali ni mzuri sababu utatoka huko ukiwa umeangaliwa kila kitu kuliko nyumbani. Nyumbani kuna vitu unaweza acha kama hii bleeding haujui una bleed sana. Lakini huko watakusaidia, utapata hiyo bleeding itastop, kuna sindano unaweza dungwa.
Another young mother on her own journey is 23-year-old Christabel Juma. A mother of one and currently 5 months pregnant, her pregnancy has not been easy.
Hii nayo nimegonjeka sana. Nilikuja nikapima damu pia ni kidogo. Wakaniambia ninunue dawa, nimeza, kukula shida. Nasikia kizunguzungu, yani nguvu inaisha kwa mwili. Kutembea shida. Nikisimama nasikia hizi miguu zimeisha nguvu. Alafu inakufa ganzi.
Getting balanced meals every day is not easy, but she keeps going to clinic. In her first pregnancy, Christabel gave birth at home, but this time round, she's confident of delivering in hospital.
Sasa nyumbani mtoto akaanza kuniuma. Na nikasema kanipeleka hosi. Sasa vile tulifika hosi, daktari akasema njia za mtoto bado.
These personal stories are part of a bigger change happening at the Gataka Health Center in Kajiado North. For years, the facility had no ultrasound machine. Expectant mothers had to be referred to private facilities for scans at high costs. Facility in charge Agre Omanga explains.
And our only public facilities are Rongata Rongai and Ngong Sub-County Hospitals, which offer the ultrasound services at a fee, like 1,000 shillings. But when they go to the private facilities, they are being charged a minimum of 200 and a maximum of 1,500. So by the end of the day, you find that the population that we are serving are not people who are well off, so they lack these funds. And when you refer these clients for the ultrasound services, they go and they disappear not to come back.
The introduction of portable point-of-care ultrasound POCUS means instead of referring mothers outside, clinicians can now do bedside scans at the facility.
POCUS is going to change the maternal child health in so many ways. Number one, we'll be able to identify some of the conditions early, which maybe need some early interventions, because sometimes, as we've known before, is that maternal mortality has been high as a country. We've been experiencing mothers losing their lives while in delivering, even after delivery. And so some of the causes are avoidable actually if early diagnosis is done. And so through the POCUS, which is the point of care ultrasound, which can be done actually by the bedside, so you don't have to refer a client outside, so we can be able to maybe diagnose if there are any conditions that need early interventions before it's too late to intervene.
Government guidelines require at least 2 ultrasound scans in the first and third trimesters.
It used to be 4 visits, but now we are doing 8 visits. However, we have not reached the target, because some clients also, we have some challenges of clients coming in late. They start even as late as second trimester to come to the clinics.
In the Mama and Mona program, mothers also receive delivery packages when they start antenatal care, a small but powerful incentive that encourages early clinic attendance.
The uptake of antenatal clinic has improved because of the program that came in, the Mama and Mwana from St. John's, and we really appreciate their efforts. And the CHPs, on the other hand, have been working so hard with the St. John's to make referrals of these clients to the facility.
6,000 women die in Kenya due to preventable maternal deaths. That translates to 16 of them each day. It is such initiatives that bridge the gap to ensure that expectant women continue to receive maternal health education and timely care. Beyond the hospital walls, community health promoters play a major role. They follow up mothers at home and encourage clinic visits. The result? More women delivering in health facilities, more early antenatal visits, more mothers like Brenda and Christabel getting help before it's too late.
Kuattend clinic lazima uattend kila mwezi na uanze mapema. Ukianza mapema inasaidia kuliko uanze late, because kuna vitu wataangalia wapate za kurekebishwa mapema kuliko ungoje hiyo siku.
Maternal mortality has been high as a country. We've been experiencing mothers losing their lives while in delivering, even after delivery. And so some of these some of the causes are avoidable actually.
Of course, for you to have a safe delivery, you must also have some good practice in the sense of the health tips. So looking after your health during pregnancy is one of the most important things you can do for yourself and your baby, from the early days of pregnancy through delivery and even after birth. So here are some tips every mother can follow to stay healthy and strong on this journey. Maternal health is vital for the well-being of both mother and child. Taking care of yourself during pregnancy, delivery, and after birth helps prevent complications and ensures a safe delivery. Here are tips every mother can follow to stay healthy and strong throughout this important journey. First and foremost, attend antenatal clinics early and regularly for checkups and screenings. Eat a balanced diet with fruits, vegetables, whole grains, proteins, and iron-rich foods. And take prescribed supplements such as iron and folic acid as directed by a health worker. Drink plenty of water and avoid unsafe foods. Get enough rest and avoid heavy physical work. Avoid alcohol, smoking, and drugs during pregnancy. Sleep under treated mosquito nets to prevent malaria, and get tested for HIV, syphilis, and other infections as recommended. During delivery, deliver in a health facility with skilled health personnel. Prepare a birth plan including transport and emergency contacts. No danger signs such as heavy bleeding, severe headache, or high fever. After delivery, that is postnatal care, attend postnatal clinics for mother and child. Practice exclusive breastfeeding for the first 6 months if possible. Eat well to regain strength and support milk production, and seek help for excessive bleeding, fever, or pain. Last but not least is mental and emotional health. Talk to someone you trust if feeling overwhelmed or sad, and seek professional help if you experience prolonged sadness, anxiety, or stress. So on that note, we take our first break, but there is more to come in as far as some of the interventions that are being put in place for maternal health care. And welcome back. St. John Ambulance is well known for its emergency response and first aid training. But now it is also making a real impact in maternal and child health through the Mama na Mwana program. Elizabeth Wamoya is a long-term volunteer with St. John and the program lead. She tells us more about how this initiative is saving lives.
So Mama na Mwana has been in existence for close to a decade in Africa. It's currently taking place, or rather the program takes place in Zambia, Zimbabwe, Malawi, and Uganda. So just recently, less than 2 years ago, Kenya would be the 5th country to be picked in terms of cascading and implementing this particular program. Important to note is that maternal and child health is basically one of those areas that we need combined intervention, and it's a process. So with that, we know that in Africa, the rate of mortality and maternal mortality and neonatal mortality has been quite a work in progress. And also Kenya, respective of us having done quite a lot in terms of gains, we still have the burden of trying to break down the maternal and neonatal deaths.
What are some of the indicators that you could talk about when it comes to the Mama na Mwana project? Because before that, there could have been some challenges. You could talk to us about that. And what do you think is the impact of this particular project?
We realized that, first of all, a lot of our mothers are very, very, very young. I think in the program, the youngest we've had is 10 years of age. So with that when you have that bracket of very young, I'll call them mothers, automatically in terms of information, they don't have any information around maternal health, around the antenatal and all. So the moment that we are able to work together with the community health promoters, they are actually able to cascade information. And this is information that, first of all, we ensure we take them through a training on maternal and child health, so that even as they get down to the mothers that are in their region, they're able to impact them with knowledge. So what happens is that once they get the knowledge, they are able to know the importance of even being able to attend their clinics. They're able to know that for them to get a baby who is at least live and healthy, and even for themselves to be safe, that they are able to deliver in facilities with a reason on the same. For this particular project, we work very, very closely with all the public hospitals. We currently are working with Ongata Rongai Sub-County Hospital, together with Ole Kasasi Health Center and Gataka Health Center. So we also recognize there are other private facilities, close to 17, that actually support the same maternal and child health. So as we initially spoke, we said that they needed the information. And once the information is actually passed through the trusted partners, and that is the community health promoters, then one, at facility level, there'll be an increase in uptake of the antenatal services and also the what you call the child welfare clinics uptake. So with that now, we have seen that initially we had a bit of lower numbers, and especially with the exit of NHIF at a particular point. But what happened is that with a lot of work done even towards awareness on the SHA program, which also has a component of maternal and child health in terms of delivery and also antenatal clinics, then with the increased registration of the same, then the mothers are able to deliver in the facility. So we've seen increased uptake in the antenatal clinics. We've seen also increased uptake also of subsequent clinics like postnatal, that is 2 weeks after delivery. We've seen increased uptake also of mothers who are bringing in their babies for subsequent immunizations. So this is a key indicator, not only for us as St. John, but also at county level and national level, where we aim to increase access of healthcare to our communities.
So where do you think the gaps are, and how can you tie them up?
So we have what we call low uptake of antenatal clinics for mothers in the first trimester. And these are mothers who are from the onset of pregnancy to about, give it 12 weeks. And maybe traditionally, most mothers know that they're supposed to go for antenatal clinic when the stomach is like, well, it's protruding. So you'll find that there are various reasons why the mothers may not come over to the facility. Spans from also, in case it was a very young mother, maybe give it even 13 years, who comes and maybe fears that they'll sit at the same seat, waiting bay area with maybe somebody like me who's above 40. So you'll find that some of them will have a bit of some, they will be a bit resentful about coming in for clinics. We also look at it from a perspective of children also who, I'll call them children and mothers in the same breath, who may feel that I'll also wait, and maybe the parents will tell them just wait a bit, and then maybe you start clinic later on or somewhere far away. So like for this particular indicator around uptake of the antenatal clinic, we are at roughly about 2%, right? And this is as a program as per the cluster we are working with. However, for the year 2026, we aim to increase on that. The other area is around exclusive breastfeeding, where a baby is supposed to breastfeed until 6 months. So we realize that also that is a bit of a challenge, but with that it means we put in other disciplinary, other departments like nutrition department, and also work together with the community health promoters to see how we can cascade what could be the challenges of the mother who cannot be able to breastfeed the baby up to 6 months, right? And that maybe we can see how to support on the same. So those are the two critical indicators that in 2026 we really need to work hard on the same. So we mentioned that this would be the pilot phase for this particular program in 2025. So initially we were meant to reach 3,111 beneficiaries, that is the pregnant mothers, and also those who have what we call new mothers, those who have just delivered. and also able to reach 800 fathers and reach out to close to 12,000 community members. Come to the close of 2025 in December, against 3,111, we were able to reach 4,100 mothers. Against 800 fathers that we were meant to reach, we reached close to 1,500 fathers. And in terms of community awareness, we moved from the target of 12,000 to about 24,000. So in terms of rating and percentage, we can say that we achieved 246% in terms of implementation. But needless to say, of course, there are various indicators that we have to look into. There's what that has happened very well, but we're also keen to look at those indicators that we need extra effort.
Okay, so there's the issue of, can I call them incentives that you give through the Mama na Mwana project? What would you say has been the impact of these commodities that you actually give, can I say, to the health facilities and also to the beneficiaries?
I'll start off from at community level. So what we do is that we also offer what we call mama packs to mothers who are now in the third trimester. And this is with a plan because you want to make sure that even as they put their bags together to get ready for delivery, we've seen cases where some don't even have anything, not even a wrapper for a baby, a bucket, or even a pair of slippers, or even sanitary towels. So what we do is that for each and every mother who's in the program, by the third trimester, they're able to get a mama pack that has got a base and slippers, name it, everything that you'd want immediately that you get the baby. So we've seen that has really brought about a lot of, they get content and they find that this is so, it speaks to them, speaks to their heart, and you find that they now get even more motivated to come for clinics. That's one. Then two, it becomes also easier for the community health promoter because when they know that they're able to get that, they're also able to refer other mothers to come over and start clinic early.
Mm-hmm. It's been a very big challenge, especially, can I say, in the rural areas, but we are really not in the rural at the moment. You know, here we actually in the town, in Rongai, and still public health facilities don't have certain, can I say, equipment that are needed in terms of ensuring the health of the mother and child, especially during pregnancy. And so you've actually worked to ensure that, there's an ultrasound that is going to be delivered, to this particular facility. Talk to us about some of the challenges that these women have been going through, but more so about the impact of what you think this kind of equipment is going to enhance in these kind of facilities.
In our pilot phase, we realized that a lot of mothers had a challenge being able to pay for ultrasound services and also what we call the antenatal services, which are basically the tests that are undertaken when you're pregnant. Some of them, the hemoglobin level, what you check, what we call the VDRL, and also maybe other tests. So with that, they found it that it was easier for them to stay home and wait and maybe come when the pregnancy is established. And yet, if it's a mother who is at risk, for example, if it's a mother who's got maybe high blood pressure, for example, or if it's a mother who may get antepartum hemorrhage in the process, you see it becomes very difficult to know if there's an issue, right? So for a long time, even as we do our monthly meetings with the community health promoters, we have statistics that were able to show that X amount of mothers were not able to access ultrasound services, and yet as per the antenatal clinics, they are supposed to have 8 visits, and you see, for them to even achieve that, it's quite a tall order. So through the St. John's International, we were able to lobby and see how best can we be able to accelerate this particular service. And in the process, it was a privilege to stumble upon a conference by Mediglobe and Hatch Technologies, who would be able to teach on what you call the point of care ultrasound, known as POCUS. And with this, being cognizant that we don't have so many like radiologists who are available. The lovely thing about it is that this is something that is nurse-led, can be done by the nurse, can be done by the clinical officer, and in turn, so that at the first contact as you have with the mother, the nurse doesn't need to stumble. The nurse can be able to check and see if the fetal, how the baby is faring on in utero. So when I saw that it was good, I was able to pitch it off to St. John's International, and we said, let's try it. So out of the 5 African countries, once again, Kenya would be the one implementing this for the Mama na Mwana program. So we are really excited because this has come to fruition, and we've been able to train around 13 to 15 nurses and clinic officers who will be able to offer the service to the pregnant mothers. And the beauty about it is that the mother will not have to pay even a coin. So automatically we see, in terms of access, these mothers will be able to go home knowing the state of their babies in utero.
We've come to the end of the program today. Thank you so much, as always, for your time and your company. Remember, if you've missed any part of this program, you can always catch it on our YouTube channel. My name is Marie Yambo. On behalf of everyone who made this program possible, we hope to see you again next time.